Well, good afternoon, everyone. You can see this is a tall podium for a very tall speaker. Tall in many, many respects, in addition to stature physically, but also stature more broadly in the medical and healthcare community. I'm really delighted this afternoon to welcome Dr. Richard Besser to Stanford. Many of you are familiar with his work as Chief of Health and the medical editor for ABC News, where he covered the Ebola outbreak in Liberia, and also shed light on critical global health issues in a series of reports from 7 nations. You may also know Dr. Besser from his long career at the CDC, including a period as acting director in 2009 when he skillfully directed the agency's response to the H1N1 flu epidemic. Now, despite his impressive background and resume, Dr. Besser's most influential position may be his current one, and that is President and CEO of the Robert Wood Johnson Foundation, the largest philanthropic organization in the country focused solely on health. One of the many things that excites me about the Foundation's work and about Dr. Besser's leadership is the focus on the social determinants of health and trying to bring more equity into health and healthcare delivery. People's behavior, environment, and living conditions play a much more significant role in healthcare outcomes than we've traditionally recognized and addressed in the past. For too long, the medical community would treat a person's symptoms without considering how the conditions at home might impact these symptoms and their overall health. It was a vicious cycle that exacerbated inequities already apparent in the healthcare delivery system. Now, institutions like Stanford Medicine, with our precision health commitment to treat the whole patient, and powerful advocates such as the Robert Wood Johnson Foundation, with their ability not just to educate the public, but also to bring researchers together and to look forward at how we break that cycle, now I think we're really poised to have tangible and meaningful effects moving forward. We're a proud partner of the Robert Wood Johnson Foundation in a number of projects across Stanford, and I'm pleased that Dr. Besser is joining us today to share his insights and perspectives. He'll speak to us this afternoon about the Foundation's work, and he has graciously agreed to take questions after his remarks. Please join me in welcoming Dr. Richard Besser.
Well, thanks very much, Dean Miner. It's truly a pleasure and a privilege to be here at Stanford to speak with you today. As the Dean mentioned, we have a long relationship with Stanford. We continue to support a lot of work here and view Stanford as a real leader in innovation and a thought leader around the nation when it comes to health. What I want to do today is talk about our work, what we're focused on, talk about our vision for health in America, why we are doubling down on our commitment to health equity and what that means. What do we mean when we use the phrase health equity, and why do we think it's absolutely essential that it's always part of the conversation? I'll talk about the primary focus areas for the Foundation, and then give you some examples of our work. And as the Dean mentioned, my favorite part is always the Q&A at the end. So our foundation is relatively young as foundations go. We were founded in 1972 from the fortune of Robert Wood Johnson II, who built up Johnson & Johnson, the pharmaceutical company. He left the largest part of his fortune to start a foundation with a focus on improving health and healthcare in America, in particular for the most vulnerable. And that's it. Those were the parameters around which we were set up. And over the early years of the foundation, we were divided into 2 fairly distinct silos, one that focused on health care and one that focused on public health. And in the public health basket were social factors. Over our history, some of the things that we're proudest in terms of accomplishments, we helped build the 911 emergency response system in America. We contributed greatly to the reduction in rates of smoking, focusing largely on preventing children from starting smoking and helping those who smoke to stop. We invested a lot in building the field of palliative care in America. We have always invested in and continue to invest in nursing leadership. A lot of work around mental health in the early years. And then one of our more recent big bets was around childhood obesity and trying to stem the tide in childhood obesity. But I would say over the past 8-9 years, the foundation has come to realize that so much of health is unrelated to health care, that only a small part of someone's health trajectory has to do with being connected to a healthcare provider. It's important. I mean, everyone should have a right to high quality, comprehensive, affordable health care. But even with that, if everyone had that, we would still see major disparities. So about 6 years ago, the foundation embraced what we call a culture of health for America. And by that, we mean a recognition that health occurs due to the conditions in which we live and work, where our children learn and play. And we need to address those factors if we want to improve health. Early exposures in early life can define the trajectory for a child, not just through childhood, but throughout their entire life. Access to housing that's safe and affordable, schools that provide a good education, healthy food, places to play, secure jobs that pay a living wage. These factors are all critically important to health. And then the importance of removing barriers to health caused by racism and sexism, ageism, and other forms of discrimination. These are all critically important to whether or not someone will experience health. I've seen this throughout my career as a general pediatrician. I've been very fortunate in all of my jobs that I've been able to continue practicing general pediatrics. And each of those settings has been in a federally qualified health center. And the federally qualified health centers provide really the safety net across America, seeing patients who are on Medicaid, patients without insurance. That's where I've been able to really connect to all of the other work that I've done in my career. And I remember when I was still in Atlanta at the CDC, I spent 9 years there working in a clinic that mainly saw Latino patients. And there was this little boy, he was 4 years old, and he wasn't gaining weight. And he'd been coming to the clinic for a while, and we would bring him back for frequent weight measures, and I examined him, and I couldn't find anything wrong, and I would talk to his mom, and was really trying to figure this out. We couldn't figure out why this child wasn't growing. And it wasn't until the registrar in the clinic developed a degree of trust with his mom that we learned that he was hungry. He didn't have enough food to eat. And his mom wouldn't say that to us, but she would say it to the registrar. And he was hungry because he was an undocumented immigrant. He didn't have access to the safety net programs in America. So we were able to connect him to a food bank that was able to provide him with food. But the idea that in 2019, there are children in America and adults in America who are hungry should be unacceptable to us. And 1 in 6 kids in America live in a household that is food insecure, meaning they don't know day to day whether there's going to be enough food to eat. In New York City, I worked for 8 years there in a clinic in Harlem. That 80% of the patients we saw there were in the foster care system. And I remember this grandmother. She was providing foster care for her 2 grandchildren, and she lived in Staten Island, and she would travel a couple hours on public transit to be seen in the clinic in Harlem. And I would go through my history and my physical, and having been at the CDC, I knew the exercise requirements very clearly. And say, your grandchildren really need an hour 5 times a week outside with rigorous physical activity in order to be healthy. How much time are they having outside playing? And she said, well, they're not really outside playing. And I said, well, you really got to get them outside playing because that's going to be good for their health. And she said, it's not safe. I would love for my grandchildren to be outside playing, But in our neighborhood, they just can't do that. So the idea that we put out recommendations that make a lot of sense, but don't recognize the barriers that are there for so many. Another child in that clinic, 3 years old with asthma, kept recurring, kept coming back to the ER. Eventually, we ended up doing some allergy testing, and the child was allergic to dust mites. These are little critters that live in the dust in most buildings. If your child has asthma, they can really cause a problem. And so we wanted her apartment to be cleaned. Well, her landlord didn't care about that. He would rather have a different tenant than spend the money to clean that out. And now I'm working in a clinic in Trenton, New Jersey. And a couple months ago saw a mom there who has a 5-year-old child with severe developmental disabilities who needs special services and is entitled to those services. She's been waiting over 2 years to get that child the services that he needs. And I know that in Princeton, where I live, that wouldn't be the case. So these are some of the things that bring to life to me the importance of thinking about opportunity and how opportunity plays into people's ability to lead healthy lives. So at the foundation, when we think about a culture of health and all of these factors, we talk a lot about health equity and the importance of health equity. From my time at ABC News, I've learned a lot about words and language and how the words you choose can either bring people together and build bridges or can put up a wall. And equity and health equity is one of those words that sometimes puts up that wall. And so we've spent a lot of time exploring the meaning of that word and trying to explain what we mean by equity versus equality and how those come together. And so here's a graphic that we developed to try and explain that. So say you have a situation and you want people to ride their bikes. And so in the situation of equality, everybody gets a really nice bike. They're all the same bikes. Well, you can look and see what happens there. The girl there on the left in the wheelchair, she's not going to use that bike. The next guy over, he's like me. He's going to ride that bike, but he's going to end up with a really bad back because that bike doesn't fit him so well. The woman next to him is doing great, and the kid, his feet don't even reach the pedals. So you say, they all got a bike. How come they're not making the healthy choice? Down in the lower part of the graphic is what we mean by equity. And here, everyone is getting what they need to make that healthy choice. So the girl who has a disability has a bike that works for her. The tall guy has a tall bike. The woman's still got that same bike. And the little kid has a bike that he can ride. That's what we mean when we talk about equity. And when it comes to overall health, what we're talking about is creating opportunities and removing barriers. And those barriers can relate to income, to gender, to geography, to your physical abilities, to your age, to your sexual orientation, to your immigration status. And the one area that's so hard in America to talk about, and that has to do with racism and discrimination. And we're spending a lot of time trying to join the conversation that is going on or should be going on around those barriers. When we think about how we frame that conversation, we try and tie it to what are considered to be traditional American values. So values, we say that all men are created equal. Not all people, but all men are created equal. We pledge allegiance with liberty and justice for all. We talk about America being a land of opportunity and the American dream of pulling yourself up by your bootstraps. But we haven't lived up to that ideal. Our history has been filled with barriers that have been set up at every level of society, deeply rooted, many times intentional, that continue to limit the opportunity for so many. Some groups have lifetimes of benefits and opportunities because the system was set up that way. Others have barriers and burdens that have nothing to do with how hard they work, how much education they have, because society set it up that way too. So when I think about the work of our foundation, a lot of it is trying to bring that into the conversation around health. When I joined the foundation, we had a team that focused on health equity, and they were doing their programming, very good programming around health equity, doing funding in that arena. But as we we talked about health equity and how we view its relationship to health, we realized that having a health equity team didn't make sense. We needed to make sure that health equity was being built into all of our programming and all of our work. So about a year ago, we got rid of our health equity team. And what we did was we made every one of our program areas responsible for health equity. It's built into their strategic plans and their work. And in their programming. And this is clearly aspirational. We have a long way to go here, but we're committed to doing it, and we believe it's the only way we can make a lasting difference. We believe strongly in the power of data to shine a light on some of these issues. And over the course of our history, over the past 10 years, we've had a product called the County Health Rankings. And these come out once a year, and they rank every county in every state in America, or just about everyone, by a variety of health measures. There are 40 specific health measures. Many of these are conventional things like rates of diabetes and smoking and teen pregnancy and obesity and premature deaths. But we also look at factors that have a big influence on health and well-being. Things like unemployment rates, failing schools, substandard housing, segregation rates, rates of persistent poverty. And last year, for the first time, we broke the data down not just by place and where the county was, but by place and race. And the findings were eye-opening, but not surprising. Health indicators for Black Americans, for American Latinos, for Native Americans across the board were worse than they were for whites. Even if you lived in a top-ranked county, there were health disparities by race. Here's just one example. Black babies across America more than twice as likely as white babies to die before reaching their first birthday. The rate for babies born to black mothers is 11.1 per thousand. For babies born to white mothers, it's 4.9 deaths per thousand. And if you're thinking, well, maybe race is just a marker for education level, that's not the case. This is a study by Brookings that looks at infant mortality by race and education level, and I'll orient you to it. Across the x-axis, it's breaking women down by how much education they had. So on the far left, it's 8th grade level or less. On the far right is an advanced professional degree. The darker bars are for black mothers, the lighter blue bars for white mothers. And what you see is that the infant mortality rate for a baby born to a black woman who has an advanced professional degree is higher than that for a baby born to a white woman with less than an 8th grade education. I find that to be just stunning. And once a child is born, the situation doesn't get that much better. Raj Chetty, who we have funded and spent quite a lot of time here, he did an analysis looking at upward mobility. And when we think about the American dream, it's this idea that if you work hard enough and you're committed, anyone in America can achieve. And what he looked at was children by race who were born in various income levels in America, and the likelihood that they would be able to move up, or if they were born into a wealthy family or high-income family, the likelihood that they would stay there. And here's what he found. Black boys in low-income homes, 2.3% were likely to make it to high income. 4 times as many white boys were able to make that rise. And if you're born into a high income home, white kids more than twice as likely to stay high income than black kids. When I think about our work around health equity, we do a lot of our work through partnerships. And just last month, we announced a partnership that we're very proud of, and it's with the NAACP. And people say, well, why is a health philanthropy partnering with the NAACP? For a couple reasons. We look to see who is connected to various communities across America, and there's no organization that has deeper roots in communities of color than the NAACP. The NAACP is about civil rights. And when we think about what's required for health, it's really about having agency to make change within the communities in which you live. And the NAACP is about that. How do they organize people to identify problems and address those problems that they see? For us, it's a natural fit. The other thing that's been wonderful, we've worked with them for about 10 years before entering the strategic partnership, is that they see the importance of bringing health into the conversation and looking at the health within the communities they're living as a fundamental right. So having them working on civil rights and also health rights, having us be part of the conversation and talking about civil rights when we talk about health is absolutely a wonderful connection. I want to shift and talk about our focus areas. We are a large foundation, $11 billion foundation, one of the largest in the nation. We spend about $500 million a year focused on improving health in America. And while it's a lot of money, when we think about what we're focused on and shifting the conversation in America around health, shifting these big societal factors that are drivers in health, $500 million isn't a lot. We're up against a $3.7 trillion health system and major issues in all aspects of society. But we feel it's important for us to be dealing with these big, very challenging problems. I want to give a shout out to a new book that was written by a Stanford professor, Rob Reich. It came out this fall, and it's called Just Giving: Why Philanthropy is Failing Democracy and How It Can Do Better. And I think it's a really brilliant critique of philanthropy, but it also paints a path for how can philanthropy, which is truly part of a plutocracy, and we are able to decide what we do and what we spend our money on without much of anyone having a say in that. But how we can contribute to a democracy. And part of that is taking risk, staying with problems for a long period of time, and investing in things, in research and other things that can help inform public policy and help inform the democratic process. And that's what we're trying to do. We have 4 focus areas, and I'll touch briefly on those. So much of our work is around shifting mindsets in terms of what the drivers truly are of health in America, advocating for policies that will lead to systemic change, supporting research to inform those policies, and supporting leaders to have the agency to identify and address the problems that they see. So first, creating healthy communities. This is all about creating those conditions that I was talking about, or that I see in the clinic every week when I'm there. The communities that don't allow people to make healthy choices. Generating data to help communities identify and address the problems that they see. So that's some of that county health ranking work. Supporting local policies that encourage healthy living. Making health and health equity part of the conversation in community development. I went to this conference in the fall of this program that we have where we're connecting people who are involved in housing development and health together. And there was a woman there who spoke, and she said she'd been working on urban development for about 20 years, and she had never seen the connection between what she was doing and health until she participated in this. And just through the ability to convene and pull those two sectors together, public health and housing, they saw their work in a whole new light. And it was really an incredible thing to see. So much of our work now is about trying to get sectors that hadn't worked together to collaborate and work together to improve community health. And then encouraging residents themselves to set the goals that resonate within the community. One of the critiques of philanthropy is that we're as ivory tower as it gets, and if we're sitting in Princeton deciding what the priorities are in a community that's affecting change, we're not going to get very far. So it's how do we cede some of that power and allow communities to identify and address the challenges they see. One of the tools that we give is something that I find to be incredibly powerful, and this is zip code maps. This is providing data that shows the connection between where you live and your life expectancy. This is work that we did in conjunction with Virginia Commonwealth University's Center on Society and Health. And this map is Atlanta, Georgia, where I used to live. And at the top there in the center is an affluent neighborhood in Buckhead. And according to the 2010 census, 83% white. On average, people living there live to be 84 years old. In the left-hand corner, just west of downtown, that's a neighborhood called Hunter Hills. 96% African American. The life expectancy there is 71 years. So a 13-year difference between those two. These kind of maps, I think, bring to light for people what we mean by differences in opportunity. The clinic where I work in Trenton, life expectancy is 73 years. Where I live in Princeton, which is 15 miles away, it's 87 years. So 15 miles, 14-year difference in life expectancy. And these kind of maps have taken off. Here's one that was developed by the Federal Reserve Bank here in San Francisco. And this map, it's a BART map, and it shows life expectancy by BART stop. It's unbelievable. It also shows median income, college education rates, rates of hospitalization. The Walnut Creek stop on the yellow line, 84 years. 12th Street in Central Oakland, 73 years. So a decade difference in a span of about 16 miles. Just a few months ago, we took this a step further, and through a collaboration with the CDC's National Center for Health Statistics, we provided life expectancy maps by census tract for the entire nation. So if you go to this website and you put in your address, it will tell you what the life expectancy is for someone living there. I've spent hours like typing in addresses and looking. It becomes a little addictive. So don't do it during my talk, but later on it would be a wonderful thing to do. But it lets you, it can let leaders zero in on differences by neighborhood and ask the question, well, why is the life expectancy for that part of my town or my city or my county different than another? Let's unpack that a little bit and see what we can do to address that. The second program area I wanted to talk about is healthy children and families. And this is due to the recognition that what happens in early childhood is so incredibly important. Here, a lot of our work is now focusing in on shifting the mindset. We say in America that we really love children. That children are the future. Everyone loves children. But when you think about it, we don't value all children the same in the sense of worthiness. Which children are worthy? And if you look at how we fund things, you would think we hate children. Because the portion of the federal budget that goes to support children is absolutely minuscule. And while we may say we love children, we don't care so much for their families. So, I've yet to meet a parent in clinic who doesn't know what their child needs to thrive. But as a society, we are really reluctant to give those parents what they know that their children need. So shifting the mindsets around not just children, but the importance of families and supporting families. So creating conditions that help children achieve the best of physical, social, and emotional well-being. Looking at policy changes that give families what they need to raise those kids to be healthy, and then putting child well-being front and center at the federal, state, and local level around policy agendas. We were thrilled when we heard that Nadine Burke-Harris, one of the best communicators about adverse childhood experiences and early childhood, was named the first Surgeon General here in California. And I can't wait to see, I know the governor's put some money in around addressing adverse childhood experiences, and we're going to look on very closely to see what happens when a state decides that they care about this and want to do something about it. Partnerships are really important in this part of our work as well. One of our strongest partnerships is with the National Y. And I just love this connection. When I always thought of the Y as the swimming gym. That's where you go. I learned to swim at the Y, and they have summer day camps. But The Y is one of the most connected organizations in America. It cuts across the political spectrum. It's in red states, it's in blue states. There are 10,000 communities across the nation that have a Y. They have 22 million members. They're also the nation's largest purveyor of daycare services. They're one of the largest providers of diabetes education in America. And they are firmly committed to health equity in the work that they do. And so having this organization that is so trusted by so many, talking about the same things that we're talking about, carries a lot more weight. Take a look at this.
Your zip code. Just one number different, and you might have a whole other life. Different school. Different job. Different dreams. Different problems. In America, the zip code you're born in can determine your future. The Y works to change that, with programs and services that help everyone thrive, no matter who you are or where you're from. For a better us, support your local Y today.
I just love that. It's the same message that we put forward, but coming from the Y. It doesn't come at you as we are talking about health. It talks about the fabric of society and what it takes to create those conditions. The next area of work that I wanted to talk about is our work around healthcare systems, because we still are very engaged in work around healthcare. And here, the big focus is on encouraging healthcare and public health and social services to come together and work to meet their patients' overall needs, total needs. One example of work in this area is work that we've done with the National Center for Complex Health and Social Services, and this is work that came from the recognition that there is a group of patients who are frequent users of emergency departments and other hospital services, who come in who have many challenges unrelated to direct medical care. So issues around homelessness and food insecurity and low income and lack of transportation, and the idea that if you provide wraparound services to those individuals, you'll improve their lives. You'll also cut down on the cost for your institution, and you'll improve the quality of care. So we were an early supporter of Jeffrey Brenner's work in doing that in Camden. We partnered with Atlantic Philanthropies and the AARP to support the launch for the National Center for Complex Health and Social Needs. And I just wanted you to hear what one of the people in that program had to say about it.
When I first found out that I had diabetes, it wasn't like somebody sat down with me and said, Troy, this is you. They didn't tell me, okay, you have diabetes, this is how you can control it. They just gave me a broad, general outlook of it and whisked me out the door. One day I woke up and I realized that my vision wasn't like it used to be. Neuropathy in my feet and in my hands. Then I had an accident, stepped on a nail. One morning I woke up and my foot was so big, it had blisters and everything. Because of my diabetes, it wouldn't heal. It's like dominoes. One thing goes wrong and it don't stop. I think I was in the hospital at least 5 or 6 times within 6 months. By the time they got to my foot, the doctor said the best treatment for you is amputation. What's the use of living? Why am I doing this? I'm not getting no better. You rather sit there and suffer. Then when you suffer too much and you don't do what you're supposed to do, you wind up back in the hospital. After my amputation, I got involved with the new way of healthcare. They try to involve the whole individual. It's like a 100% checklist. Transportation was my biggest problem. They were there to help get me a ride back and forth to the doctors. It was hard for me going up and down the steps because I didn't have a railing that was strong enough. They knew if he falls, he's going to be back in the hospital. So they had a team come in and put in new railings for me. They gave me a list of organizations. If you don't have access to healthy foods, if you can't get out, they'll bring it to you. Now I can manage my glucose readings, get good numbers because I eat the right things. They thought outside the box. Your quality of life changes dramatically. If it wasn't for the new way of healthcare, I wouldn't be where I am now.
I think these kind of programs are terrific in addressing what I would think about as kind of secondary prevention. When you have somebody who already has a condition, how do you ensure that they have the best possible outcomes by addressing those social needs? A lot of our work is looking further upstream than that and saying, how do you reduce the likelihood that that gentleman would have diabetes in the first place? And how do you make that part of the responsibility of the healthcare system, or connect the healthcare system so that it's driving change in other sectors that it doesn't have oversight of. That brings me to the fourth area of focus for us, and that's leadership for better health. Since our founding, we've always invested a lot of money in leadership development. The Robert Wood Johnson Clinical Scholars Program has trained the leading health services researchers across the nation and was really our flagship program. I remember when the foundation decided to revamp the leadership programs and get rid of that program, phase it out and reshape it. I was one of the people who called and said, "What are you doing? This is crazy." Everyone I've worked with who's been in that program has been outstanding. And what was said to me then and what I see now is that if you really feel that the solutions to these problems are going to come from the people most impacted, from people at the community level, we need a different type of leader. And so we now have 4 change leadership programs. And I'll just run through briefly what they are. Maybe these are things that there are people in the room who want to think about applying for. But these are training leaders to work across sectors to address clinical and community challenges that they see. The Clinical Scholars Program, this enrolls interdisciplinary teams of healthcare providers, so physicians, nurses, dentists, counselors, to work on a clinical problem that they've identified in their community. The Health Policy Research Scholars, this is a program for second-year doctoral students from underrepresented populations or disadvantaged backgrounds who can bring their own perspectives to policy and research, voices that have been traditionally underrepresented in that arena. The Culture of Health Leaders, this draws people from fields that aren't normally thought about as related to health. So we have people in that program who are in architecture, city planning, technology, education, law enforcement, farming. They want to see, these are leaders who see and want to strengthen the connections between their work and the health in the communities in which they live and serve. And then interdisciplinary research scholars, this pairs 3 people. Pairs doesn't really work there. Anyway, 2 researchers with 1 community leader. So you have a community organizer, a community leader who has identified an issue in their community. They're paired with people in the academic sector who can do the research to evaluate the kind of interventions they're doing. So it's true community-based, community-informed research. A couple examples of those from the Bay Area. This is Rio Holiday. She is in the culture of health. She is a culture of health leader based in Oakland who has worked at refugee resettlement programs and a food collaborative that encourages community retailers to provide healthy food. And here's what she says about her work. She brings together residents, organizations, and public agencies to get real about about how historically marginalized communities can shape their neighborhood's future, have equitable opportunities for healthy food and safe spaces, and build community wealth. The next is a team in the interdisciplinary research program, Irene Yen, Susan Neufeld, and Leslie Dubbin. This is a group, one is a professor of medicine, epidemiology, and biostatistics. One is vice president of a nonprofit developer of affordable housing. And the third is a member of the San Francisco Department of Public Health. Their research focuses on the impact that privately funded renovation and redevelopment of public housing has on residents' health. So they've identified this problem, this issue in their community that they want to study, and we've helped bring them together to be able to do that. Last month, or in January, I went to it was my second time going to the convening of the leaders in these programs, and there were 450 people in the room who were in these leadership programs. It's my favorite conference to go to. I leave that room totally inspired that we can make this country more equitable. We can have a better future than what we're reading in the newspapers today. This is a group of people with passion and with the skills and tenacity to truly make change. The last thing I want to end with is a story of, I think, an example of a community that has brought all these pieces together to make the kind of effective change that we're hoping for. And it's in Atlanta. The community is called East Lake. It used to be known as East Lake Meadows, and it was a notoriously dangerous public housing project. So in 1995, here's what it looked like. The crime rate was 18 times higher than the national average. The most successful business was the drug trade. Nearly half the housing units were uninhabitable. About 3 out of every 10 students graduated from high school, and the unemployment rate was 13%. So around that time, a developer named Tom Cousins teamed up with local residents to establish the East Lake Foundation. It brought together residents and business leaders and people from government and philanthropy with the goal of replacing this worn-out public housing project with 1,400 units of mixed income housing, half of which would be at market rate. And I visited this about a year and a half ago and was totally blown away. Here's what it looks like today. They've seen an 86% reduction in crime, 97% reduction in violent crime. They have a 99% graduation rate, one of the best academic records in the entire state, 100% college acceptance, and the employment rate is unbelievable. The neighborhood includes a beautiful Y, a professional golf course that everyone can play in regardless of income, job training programs, and strong academic after-school and summertime programs. When I visited it, they took me through and we went and we saw these preschoolers outside playing. And the person who was giving us a tour said, "Well, what do you notice?" I said, "Well, they're having fun." She said, "Well, what else?" I said, "Well, it's a diverse group of kids. I saw kids of many different colors and backgrounds." I said, "What else?" I said, "I don't know. It's one of those read my mind things." And I said, "What?" And she said, "Are any of them obese?" And I said, "No." I said, "Well, what's your anti-obesity program?" She said, "We don't have one." I said, "We provide the conditions in which people can make healthy choices." We truly believe that personal choice is important when it comes to health, personal responsibility. But the choices people make depend on the choices that they have. And if you're not giving people healthy choices, the outcome is clear. But when you provide those choices, healthy food, places to play, good education, supportive environment, that's what they see. So, we're constantly asking ourselves, who's benefiting most from our work, whose experiences are missing, and how might that skew our efforts and our outcomes. We ask our partners and collaborators and grantees to make sure that they are doing the same, that they're asking these questions, because we can and must do better. Our founder, as I said, he wants us to work on improving health and healthcare in America, and particularly for the most vulnerable. He believed that good health enhances every aspect of our nation, and we are honored that we are continuing to work on that mission. Thank you very much. So we've got some time for questions. I see there's microphones. If you come up to a microphone, I'm calling you. Yes.
Hi, Dr. Besser. Thank you for a great talk, and I really applaud the approach to equity and community that your foundation has taken. One of the drivers of health increasingly is climate change and other environmental changes, and those disproportionately affect the poor and children. And I'm wondering how those figure into Robert Wood Johnson's work.
Yeah, I mean, I touched on our 4 core areas. There are other areas in which we're also doing some investing. We don't have large investment in the area of climate change, but we have a $5 million investment that's looking at trying to draw more attention to the connection between climate change and health. We think it's really important that as people think about climate change, they picture more than just a polar bear on a shrinking piece of ice floe. That they're thinking about the communities that are being devastated by the severe weather events and such. And so we're engaged in funding in that area. We're engaged in the process with the National Academy of Medicine to try and draw those links. And we may do more in the future, but we think that this is an area that we can help in the conversation.
Thank you.
Yeah, thanks. Hi.
Dr. Besser, thank you so much. Actually, thank you also, Dean Miner, for inviting a wonderful, you coming here to share with us, and really touched by actually the gentleman who actually got amputated his leg and the new way how things are being done. Actually, on a related note, I've been traveling with the first Asian American presidential candidate, Andrew Yang. In fact, I'm going to the red state of Texas in 1 day's time. And one of the really kind of interesting stats that I've learned is American life expectancy actually has been declining the last 3 years. And part of that, and actually, in fact, if you saw, Mike Bloomberg's announcement yesterday, one of the biggest concerns is opium epidemic. And one of the causes of that is opium epidemic. There's a lot of suicides for younger age groups from 20 to 30 years old. I'm really curious about, is this something that you guys are, I mean, you obviously have, stats on life expectancy, and obviously you look at that. But, is this something you guys looking into, and what are some of the things that perhaps, from your perspective, that we could perhaps, solve?
Yeah, we have small investments in the area of opioid use directly. I think that the work that we do upstream in terms of looking at creating conditions in communities for people to thrive and have opportunity is work that will have an impact on drug use. The direct investments that we're making right now around opioids are in a couple key areas. One is we're providing funding to identify community strategies that have been effective at addressing the opioid epidemic. The county health rankings also comes with a piece called the roadmaps, so that when communities identify issues in there that they want to address, it links to other places that have had success in that area. So that's one area. Another is providing some resources to get better surveillance data. Right now, you can get decent data on deaths from opioids, but not on opioid use that doesn't lead to death. And so we have funding that's connected to the CDC to try and round out that information. And then funding that's looking at evidence-based treatment and what's been shown, because there's a lot out there that's being marketed to people that's not evidence-based. We also, over our history, have invested a lot around access to care, the Affordable Care Act, and so we want to make sure that as there are changes to healthcare, that drug treatment, mental health is considered fully as a benefit and not an add-on.
Thank you.
Hi.
Hi, thanks for your talk. One thing that I did not hear during your presentation, and it undoubtedly affects many of these populations and has a large impact on health, is mass incarceration and the effect it has on these communities. So,
Yeah.
And also touching on the drug use problem that the last commenter talked about. So what is your foundation doing to address that, or how do they feel about that issue?
Yeah. I mean, it's a major issue. And one We care a lot. We care about. We don't have a ton of big investment there. We have a couple programs. We're part of something called the Executive Alliance for Boys and Young Men of Color, and a lot of the work that group is doing is trying to shift the narrative, change the narrative of around young black boys and men to an asset-based narrative. And we have a program called Forward Promise. It's based out of University of Pennsylvania. That is doing work in the area of mass incarceration. I'm really pleased that Congress passed some reform, but it's only just a start. I was really pleased when I went to the last conference of the Executive Alliance on Boys and Young Men of Color. There was someone there from Florida who was talking about this ballot initiative they had to try and give the vote back to people who had been incarcerated, who had had felonies. It's state by state whether you get your rights back or not, and whether you become eligible for any support programs and all kinds of things. And he said, yeah, we think we're going to get this ballot initiative through that restores rights. I'm thinking, in Florida? No way, it's not going to happen. And in the last election, it did go through. And talking to I heard a talk from Anthony Romero a couple days ago from the ACLU, and met with the head of Faith in Action that were very involved in this. And part of it was shifting the narrative around people who have been convicted of crimes and done their time. And it's similar to the issue around gay marriage. If you can find the right way in, you may make progress. And the way they ended up framing the issue in Florida was, do people in Florida believe in a second chance? And that frame, plus some data to show that actually there were more whites who were going to get their voter rights back than blacks, helped it no longer be a red versus blue issue.
Thank you.
Thank you.
Hi, thank you so much for commenting on your partnerships. I know those are very important and definitely a marker of success of a big endowment such as yours. I'd like to ask you about your partnership with the NAACP, which is the American Association of Retired Persons. A recent 990 tax form from Robert Wood Johnson Foundation shows a $10 million contribution to the NAACP to collaborate on nurse practitioner independent practice legislation. Can you please tell me how you think this dichotomous model, whereby the well-served receive care by a residency-trained MD and the underserved receive treatment by an NP, relates to health equity?
Yeah, we do a lot of work with AARP across a number of areas. One of the things that came out of, we funded a study from the National Academy of Medicine around the future of nursing, and we're in the process of funding the next round. And
That was the Institute of Medicine.
What's that?
It was the Institute of Medicine report called The Future of Nursing.
Yeah, they're now called the National Academy. They're renamed. But one of the things they called for in there was allowing people to practice at the full extent of their license. And the clinic I work in Trenton, I work there under the direction of a nurse practitioner. And I have to say, over the course of my career as a general pediatrician, I've learned more from nurse practitioners than I think they've learned from me. We, as a 501c3, as a foundation, we don't lobby, but we will provide evidence and data and advocate. And the data on the quality of care that nurse practitioners provide is extremely high. And that doesn't mean that there's not a big equity issue. So I practiced in Medicaid clinics in California, Georgia, New Jersey, and New York. And the access to services is night and day different. In New York City, any patient that I had in my clinic, I could get them in to see a specialist, because New Jersey kicked in a lot of money to New York City kicked in a lot of money to Medicaid, and so it paid for physicians to see those patients. In Georgia, I had to beg and borrow and play off favors to get those patients seen by specialists, even when they really needed it. And New Jersey is closer to Georgia, in my mind, than it is to New York City. Thank you.
Thank you.
Yeah. Hi.
Hi there, how are you?
Good, thanks.
Thanks so much for coming, and also thank you, Dean Miner, for hosting this wonderful session. I am very engaged in the pharmaceutical industry, and I do a lot of work around health equity, thinking about how to increase inclusion with clinical trials. And it's a very important issue, dear to my heart, and as we develop as an industry, we're thinking a lot more, like Dean Miner and all the students here, about precision medicine. And we're thinking a lot more, particularly upstream, about how to maybe mitigate some of the potential issues that are coming down the pipe. And I'm wondering if your organization is doing any thinking around that, or if you have any comments, or if you can even guide us to where in your organization we might be able to plug in on that, because I think that these are very important issues that are emerging. And only maybe 2 people are talking about them, and I'm just wondering if you can guide us.
I think it's critically important. You know, Stanford is such a leader in the area of precision medicine. I think can be a really big leader in a call for health equity in that arena. I've been in a lot of conversations around health equity, and around precision medicine, and I frequently find the issues of equity being either not on the agenda at all, or being kind of something as an afterthought. And whether you're talking about artificial intelligence or development of new testing approaches or therapies, equity has to be central to that. And it's not right now. And it's a real challenge when you think about the financial incentives around precision medicine, how you bring equity into that equation. It's real. I can let you know where afterwards. I can tell you where to plug in.
That would be great. I will find you.
Thanks.
Last question, briefly.
Hi. My background is in network news producing, and I did the medical beat for quite a while, and with Bob Bazell. And I'd like to know your thoughts on the relevance, impact, or frustrations getting that sausage made.
Yeah, I'll do that one quickly. I was at ABC News for almost 8 years, and when there was a health crisis, I felt like I had impact and a real role to be able to translate what was going on in crisis, help shape how people thought about that, and to make rational decisions. Outside of that, it was really hard to get stories on about issues that I cared about. There's not one aspect of anything I talked about in this talk that I would have been able to get on the air. And so for me personally, I remember pitching a story to World News about diabetes and this community intervention that was taking place, and we could follow these communities and move forward. And I pitched it to the anchor at World News, and what she said to me, she said, that would be a great story for Nova, which is a PBS science show. So, yeah, that was like, okay. Thank you all very
Richard,
much.
thank you very much.
Yeah.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.